Welcome back. We're going to talk for a few minutes in this third segment. And it may sound like that I'm rambling a little bit, but there's a lot of topics in healthcare insurance. There's probably enough topics to last, I don't know, half as a semester just talking about insurance and the ins and outs of insurance. And I'm just trying to give you a high-level view of the basic fundamentals of health insurance, trying to do some comparisons with property and casualty, because to some extent they do, I don't want to say go hand in hand, but they are somewhat related, especially if you get into motor vehicle accidents and subrogation like slips and falls at Walmart, different places, but trying to give you a high level. And some of these we'll get into a little greater detail as we go through the rest of the chapters in Dewar's text. But we, again, get you a high level detail so at least you understand what we're talking about as we move forward. And with this segment, we're going to talk about just, they're somewhat unrelated, but they will serve as building blocks and tools for you to put in your toolbox and as we move forward through this text. We're going to talk for a few minutes just quickly about employer-based insurance. And Dewar in her text talks about fringe benefits have been important since the 50s. Group insurance offsets adverse selection via community rating and degree of risk sharing, lowers administrative costs. Experience rated for high-risk groups, length of time series data. So high-risk groups especially, she's probably right. You're probably a little better off with experience rated because you've got more time series data. Community rated, as we said, was cross-sectional, and there's a degree of risk sharing because employer groups don't have enough critical mass that health plans feel comfortable trying to estimate and not only estimate, but to price the risk that's associated with those groups. And if you think about when Dewar talks about the 50s, if you go back to Arrow's article, and he was talking about uncertainty in medical care, and he was probably doing his research in late 50s, and he published that journal article in 1963. Just remember that there wasn't a lot of health insurance companies around at that time. The market and the environment, it was just different, and its health insurance has really taken off down, especially in the 80s and 90s, and currently now, and it's a completely different animal than not only when Arrow was trying to generate that journal article, but even when I think Dewar wrote her book in 2010, maybe. So, and it's even changed since she wrote her text in 2010. And federal law excludes limiting coverage, especially with pre-existing conditions, and states may control premium setting activities. So let's just take the state of New York. When Blue Cross Blue Shield were trying to estimate premiums for community rated, experience rated premiums for maybe their I guess the premium for Medicare Advantage, Medicaid, those type things had to be approved by Centers for Medicare and Medicaid Services, CMS. But a lot of the private insurance in the state of New York, when you were setting premiums, they had to be approved by Department of Health and Department of Financial Services. Health plans would get their, let's say they were going to start offering the sales. And sales typically, and at least in Buffalo, there were sales for employer groups in January and there were sales for employer groups in July. And it depended on how they had their fiscal year set up. But if you were trying to develop your premiums that you're going to be selling, you're starting to do your work well ahead of the time that you're going to start selling those member policies to employer groups. And so you had to get all your ducks in a row. You had to have your actuaries. They had to have all of their premiums, had to have them justified and the information that drove them. And again, it had to be approved by Department of Health and Department of Financial Services. And health insurance is tied for the most part to employment. So if it's employer-based insurance, it's tied to your employment. So as long as you're employed there, in theory, you get covered for health insurance. There's also, and you've probably heard it called COBRA. And if you get laid off, you can purchase what they call COBRA type insurance. And I think you can purchase it up to 18 months. But you have some people that purchase COBRA and they, as soon as they get their next job, they'll just drop it. And with COBRA, I think, unless things have changed, you can. So if you get laid off, if you get laid off and they offer you COBRA, you don't have to pay the premium until you actually use the insurance. So you may go a couple of months without needing any healthcare insurance. You're just not going to pay the premium because you might have a job within that time frame. So COBRA, not only is it not only expensive, but if you get laid off, you need to get back and read the COBRA regs, because COBRA regs can get a little hinky in the way that you have to pay the premium. Employer paid insurance is tax-free to the employee. So if you look at your pay stub, it's probably going to look like that the benefit that you got from your health coverage, it's not going to be in tax to you, the employee, but it's tax deductible to the employer. And it's talking about FICA, FICA tax, and marginal tax breaks. So there's some tax breaks in there for your employer for providing healthcare insurance to you. And adverse selection and moral hazard impacts the optimal insurance contracts from, between the employer group and the health plan. So if you're an employer group that's generating in a business environment or in a business market that's high risk, the premiums that a health plan is going to charge that employer group may be a lot higher than for another employer group that's in a low risk type of market economy. And now we're going to talk for a few minutes about financial and contracting fundamentals. And when I say financial and contracting, I'm thinking more in terms of not so much the contract that's negotiated between the health plan and the employer group. I'm thinking more along the lines of the contract that's negotiated between the health plan and the provider group. And again, when you go into the job market, and if you decide to work in a healthcare environment or a healthcare type market, you may work on the provider side, you may work on the payer side. And to me, it's not really going to matter which side of that financial coin you're going to work on, because at the end of the day, your responsibility is to your employer, whether you're working for a provider group or you're working for a health plan. Your responsibility is to ensure that, especially if you're in contract negotiation or if you're generating information that's going to be used in the contract negotiation, you have a fiduciary responsibility to your employer group to ensure that that contract is as financially beneficial to your employer as you can make that contract. And if you get contracts, again, whichever side of that coin you're on, if you're working on the provider side and you get this really weird contract from a health plan that looks like it has some reimbursement parameters in it that really look out of whack, or if you're on the health plan side and you have the provider groups pushing for some services or some unique reimbursement arrangements, what's always the first thing you do? In your analytical work or your negotiating strategy, what do? You always follow the money. If you follow the money, you will figure out whether to negotiate that contract and what kind of terms that you need to drive in that contract. Remember, you've got, whether you're on the provider side or the health plan side, when you come together to negotiate that contract, you are developing what they call a negotiating range. So providers have a floor. They have a floor. So they're not going to go. Let me think about this. Providers set the bottom range to the contract negotiation strategy because there is a number that they aren't going to go below. Health plans set the upper limit of that negotiating range because there's a number that they aren't going to pay more. And at the end of the day, whether you're down here at the provider or you're up here at the health plan, whichever side negotiates a contract closest to the range, to either the upper range or the lower range, that's going to be the group that's going to come out ahead on that contract negotiation. So always think about, as you're negotiating these contracts, what the information is that you have, what information do you think the other side has, and you want that range to be as close as possible to your limit that you go into. So if you're on the provider side, maybe the board of directors of that medical group has said, we need this number of dollars. The health plan on this side has told their negotiator, we need it to be, at this number of dollars. And so you're in there negotiating back and forth and trying to see which one comes closest to the number that they go into that negotiation with. Reimbursement methods impact quality and quantity of services. And if you stop and think about on the provider side, if you negotiate a contract, those contractual rates are usually good for a year. So most contracts I've seen negotiated between health plans and providers usually have a effective date of January the 1st of a given year, and they have a implied termination date of the 31st of December. So those rates are good for a year. And a lot of these contracts, because negotiation between providers and health plans can get extremely contentious. Again, I've been on both sides during negotiation, and the negotiation can get ugly in a hurry. And so they typically negotiate what they call evergreen contracts. So contracts will be, let's say, 3 or 5 year contracts. They may have a cost of living, or maybe tied to the consumer price index, or they may have some other mechanism that from 1 year to the next there are these preset inflation clauses or inflators or multipliers, depending on what terminology you want to use, that takes the rates and just increases them from 1 year to the next. And they're called evergreens because you don't renegotiate the contract. It just rolls over unless one party or the other notifies in writing the other party that they want to terminate the contract. And it's usually 30, 60-day notification before the contract expires. If it's December the 31st, at least in theory, it has to be notified if it's 60 days by October 31st. So that's just the way these contracts are set up. And since your rates as a provider are set for a year, if you need to increase total revenue, you have to either increase the number of units you're providing to drive that total revenue up, and you increase those number of units either by bringing in more patients or providing more services across patients. So depending on how the contract's negotiated, if it's fee for service, you're looking at volume, you're looking at number of units. If it's a capitated arrangement or value-based arrangement, you want to shrink the number of services you're having to provide. I want to somewhat ration it and bring in more units or bring in more members so that you can see more individuals that way. So a couple of ways for providers to increase that total revenue. And at the same time, while providers are trying to maximize revenues over here, health plans are trying to minimize expenditures over here. So they are trying to control those they're trying to control the demand for those services. So again, that's why it gets really contentious when you're negotiating these contracts, is you've got both sides of that financial coin, and neither one can afford to lose. It doesn't get to the point, where they want to win or not. It becomes a financial issue because of the viability of either the provider group or the health plan. And there are different ways that if it's a retrospective, kind of after the fact, it's based on, again, revenues based on price and quantity on the provider side, expenditures based on price and quantity on the health plan side. So if it's a retrospective payment, the payment is made after the service has been provided. Can be actual cost, it can be some kind of a contracted rate. There may be, incentives for providers, what they call churn, provide, more units of service than they need to. And there's just a lot of games that are played and, between provider groups and health plans. And again, maximizing revenues, minimizing cost. And that's what drives that both sides of that financial coin. You've also got prospective rates agreed in it, to an advance, but maybe not paid in advance. And that is because health plans, to a certain extent, at least in theory, prospective rates sometimes impact quantity, quality, access, and it actually may need to rationing. So prospective rates, you typically think of value-based rates, you typically think of capitation. You have some contracts that are based on global budgeting, so are revenue neutral or revenue incentive. So, you have providers negotiating with health plans that say, well, next year I want to increase my revenue by, I want you to guarantee I'll increase my revenue by 5% or something. So there are just some really unique type of contractual arrangements out there. And if you go into the healthcare space and get into analytical work, actuarial, medical economics, maybe you're on network management and on the negotiation side, you're going to run into a lot of unique type of contractual agreements out there. And then lastly, there's, especially on the hospital side, a lot of these hospitals have gone to what they call case rates, based on whatever the diagnosis that drives that inpatient stay. These rates are somewhat predetermined, but paid after you're discharged from the hospital. And you usually think of these kind of case rates of DRG, diagnosis-related groups, and every DRG based on whatever the diagnosis is, has a certain level of reimbursement that that the hospital receives for that rate. You can also see rates out there per diem. So based on the number of days in your hospital, let's say they'll pay $800 for a med-surg room. And if you're in there, 5 days, the hospital's going to get $4,000. So, and then you've got episodes, you've got, diagnosis-based, you've got surgical, medical type DRGs. There's a lot of these case-based rates that hospitals will see, and you're trying to control the price, not the quantity. So if the DRG is greater than the cost of the hospital makes money. The DRG is less than the cost of the hospital loses money. And so there you start seeing some cost shifting, some patient shifting, some what they call DRG creep, where you can change diagnosis information on the bill and you get paid at a higher DRG level. So there's just a lot of games that go on when you're talking about contractual financial relationships. And if you end up in a market environment in healthcare where you are have some impact on the financials, you're going to see, again, a lot of unique reimbursement methodologies out there, and both sides, provider, payer, are struggling to ensure that whatever that financial arrangement is, it is in the best interest of their side of that financial coin. And then lastly, in this segment, we're going to talk about integrating providers and third-party payers. They're, again, both sides of the financial coin, they're separate entities. They've got separate objectives, selective contracts. You've heard about, or maybe you've heard about the vertical integration. You're talking about, it could be hospital systems where the hospitals own the provider groups, and they have a financial arrangement shipped together, and they may go to the health plan and negotiate contracts together, and so brings more of a critical mass and more negotiation power for that hospital and that medical group to be working together to negotiate those contracts with the hospitals. And you'll see hospitals, doctors, ancillary type services. When I say ancillaries, lab, radiology, ambulatory surgery centers, DME, orthotics, prosthetics, just a lot of services that can be bundled under like a hospital system. And it gives them more negotiating power when they bump heads with managed care organizations. And then you've got managed care organizations versus traditional, private health organizations. The traditional plan, you hear people talk about the traditional indemnity plan. And basically indemnity plans, means that a provider bills you bill charges and you'll pay X% of those bill charges. Then the health plan pays the rest of it. So those are kind of the old traditional indemnity plan. You don't see many of those around anymore. There are a few of them exist, especially in areas that have maybe a low access rate to healthcare. When I worked at HealthNet, we had the TRICARE contract in the North region, and that included went as far south as North Carolina. And when you got down in there around, you had Fort Bragg, you had Naval Hospital Cherry Point. There are just a lot of military bases down in that part of North Carolina, but not a lot of access to healthcare goods and services. And so we were having, to send a lot of those patients down there up to that Golden Triangle, going to Duke, North Carolina State, to to seek their healthcare services. So that's where you get into access, flexibility, and costs are harder to negotiate in areas where there's not a lot of competition among healthcare providers. So makes it hard on the health plan to control expenditures, but it also makes it harder on a health plan to provide access to their covered members that they really need. So managed care organizations, depending on where you're located and what the provider community looks like, it can get extremely difficult. So keep that in mind if you go into the healthcare environment. You may want to think about the regional aspects of where you're taking that job. And then you start talking about what's called a preferred provider organization. It's different. If you go into an HMO, and an HMO is the Acronym Healthcare Managers Organization, and you've got a gatekeeper, usually a primary care doc, and they try to control everything, try to control access, try to control cost, try to control who you go to see. And a lot of those, it's just like mine's a preferred provider. Mine's actually more like a point of service, and we'll talk about that in a minute. But usually with an HMO, it's low copay, $5, $10, maybe a zero copay for a lot of services. But you have a primary care doc that's driving all of the decision-making process. And again, you have a primary care doc that's driving that principal agency relationship. And so when you're talking about an HMO, to me, at least from my perspective, you have a situation where you might have a higher probability of asymmetric information and a higher probability of the SID impact, the supplier-induced demand impact. So on the PPO, you can basically, as long as the provider's in the health plans network, you can go see any provider you want to. You can, do a lot of self-referrals and go see anybody. You've got a higher copay. Mine is a point of service. It's a hybrid type health plan. My $10 copay, I still select a primary care doc, and I go to see him, $10 copay. If I go out to see a specialist, it's usually $35 to $45 to go out to see a specialist. So mine's to me, mine is the point of service. It's the best of both worlds. I've got low copays to go see my primary care doc. In certain instances, I feel like I know more than my primary care doc does, but it gets me in to see my primary care doc. It gets my prescriptions filled. And if I need a specialist, I pick my specialist out of their provider network, and I get to go see that specialist for $35. So to me, that's probably the best of both worlds. And if you have that opportunity, it might be something you want to look into as far as your healthcare coverage and your benefit plan, that especially that your employer group is providing to you. That's going to wind up this third segment. I'm going to come back in just a couple of additional topics in this fourth section, and then that'll kind of wind us up for this chapter in DeWar's book. So hope to see everybody back in just a few minutes. Thanks.